Inhaled corticosteroids, ICS, play an important but selective role in the management of COPD. Unlike asthma, ICS are not first-line therapy in COPD and should be used only with patients who are likely to benefit. The foundation of COPD pharmacotherapy is long-acting beta agonist, LABA, and/or long-acting muscarinic antagonist, LAMA. ICS should be added or withdrawn based on exacerbation history and eosinophil count. Who benefits most from ICS? Patients with frequent exacerbations, 2 or more moderate exacerbations, or 1 or more hospitalizations in the past year, and blood eosinophil counts greater than or equal to 300 cells per microliter, tend to derive the greatest benefit from ICS, particularly as part of triple therapy, LABA plus LAMA plus ICS. In addition, when COPD coexists with asthma, ICS are generally indicated. Who is least likely to benefit? Patients with blood eosinophils consistently less than 100 cells per microliter and no history of asthma are unlikely to benefit from ICS. In these cases, risks such as pneumonia, oral candidiasis, hoarseness, bruising, osteoporosis, cataracts, and dysglycemia may outweigh benefits. What about the intermediate group, 100 to 299 cells per microliter? In this grey zone, some will benefit. Decisions should be individualized. If a patient has risk factors such as prior pneumonia, bronchiectasis, osteoporosis, or diabetes, the risks may outweigh potential gains, and dose reduction or withdrawal should be considered. Withdrawing ICS, de-escalation. Evidence suggests that ICS can be safely withdrawn when the patient is clinically stable with no recent exacerbations, blood eosinophil count is low, under 100 cells per microliter, and bronchodilator therapy is optimized, with dual bronchodilation, LABA plus LAMA. Watch carefully for worsening symptoms or new exacerbations, and if control deteriorates, reintroduce ICS. In summary, continue ICS when asthma is present, or in COPD patients with frequent exacerbations and eosinophils greater than or equal to 300 cells per microliter. Avoid routine ICS when eosinophils are less than 100 cells per microliter and no asthma. In the 100 to 299 cells per microliter eosinophil range, individualize the decisions. Withdrawal of ICS is feasible when bronchodilation is optimized and regular follow-up is in place. Now, time to solve a short quiz to reinforce your learning. A set of selected IPCRG resources will be available for you at the end of this breath.